Hello all, my name is Ben Eveslage. I'm a technical advisor for online HIV services at FHI 360, and today I'll help moderate and provide framing remarks for our webinar on next generation virtual HIV programming for the COVID-19 era and beyond. For some logistics, today we'll be using the Q&A function on Zoom to ask questions, so please ask your questions there, and feel free to address it to a specific panelist's name, or address it to all or any. That way our panelists will be able to respond to each question. These slides and the webinar recording will be shared within a week to all those who registered on this Zoom link. Next slide. So I'll start by reviewing an updated framework for going online approaches. Then we have 4 panelists who have prepared us a sneak peek into 4 hot innovations for virtual HIV programming. This will include AI-powered influencer marketing, virtual case management with QuickRes, online partner notification and home testing, and finally, telehealth consultations for mental health. At the end, we'll have time to review and address key questions presented in the chat, in the Q&A function, and then hear some closing remarks. I will introduce each of the panelists before I hand over to them. Next slide. So going online represents a portfolio of virtual and online approaches supporting HIV service delivery, tailored for remote service delivery or telehealth and client self-care, which have helped our programs at FHI 360 mitigate the impact of COVID-19 and help us better engage with the growing number of people using digital platforms. Next slide. So why should HIV programs use online and virtual approaches? We started going online in 2017 primarily to broaden outreach to previously unreached audiences and connect with this growing mobile generation. After implementing online outreach, we found these approaches also resulted in higher HIV case finding because they reached new and previously unreached audiences who had not been engaged in routine testing, but also because we found effective ways to target online promotions to subpopulations within higher risk sexual networks and who are available to be reached online. Online virtual solutions also provided clients with differentiated service delivery channels, including digitally enabled self-care, which meets many clients' preferences for self-guided engagement in health services and reduces the burden on the health system. And finally, in the advent of COVID-19, going online enabled telehealth solutions that allowed many of our programs to mitigate the impact of lockdowns and physical distancing on their service delivery. Next slide. First, I want to review our framework of approaches that support each step of the HIV services cascade. Here you can see a simplified version of the standard HIV services cascade, and we stack combination prevention above the ART cascade to represent routine engagement of program beneficiaries, whether HIV negative or living with HIV. Starting with the identify stage, several approaches have been developed and used to support learning about online target audiences and planning online HIV outreach. They include using online surveys, social media mapping, mapping the density of dating app users, setting up community advisory boards, estimating the size of online target audiences that are using online by using online advertising platforms and segmentation of these online audiences. We'll just click once to see the animation. And next are online approaches that help generate awareness and demand for HIV services. They include 2 approaches which are a bit broader, including social profile outreach, which is about online advertising, and social influencer outreach, which is about promotions with social media influencers. Click once more. Both of these approaches can help link clients directly into HIV services, which we call self-reach, or they can direct clients to start a chat or start a call with program staff, such as online outreach workers, who can assist clients to understand their HIV risk and service needs. And this one-on-one approach we call social network outreach. There are other ways to bring clients in for HIV testing and other services, such as referrals from people living with HIV, known as risk network referrals or index testing, or incentivized referrals among populations at risk for HIV, which we call the Enhanced Peer Outreach Approach, or EPOA. And these methods help link clients into HIV self-testing, plus a range of standard HIV testing technologies offered by government, community, and private providers. The online reservation and case management app, also called ORA, is a web app that allows clients who are reached online to find and book HIV services across these providers. And for clients who test HIV positive and enroll on ART, or those who test HIV negative, excuse me, and enroll on PrEP, virtual case management and cohort tracking can support their adherence and retention in the program. This can include virtual consultations with a case manager or peer navigator, decentralized drug distribution, including home delivery, online partner notification for HIV testing, and automated client reminders, such as by SMS, to stay engaged in the project. For clients on ART, this also includes viral load tracking and referrals for viral load testing. And the ORA app, as well as DHIS2-based individual trackers, have been used to facilitate the delivery of these kinds of virtual case management approaches. Next slide. So here's the broader monitoring picture. I figure that this is a bit overwhelming, but let me just point out that the condensed cascade stages at the top and the approaches below it are the same that I reviewed earlier. So we'll just click once to see this, this updated version, and this will let us focus on the results and indicator section, which are color coordinated to match the tracker tools that can be used to support data collection for those indicators. The sections in yellow show that HIV programs can leverage the built-in analytics of social media and online advertising platforms to understand their reach and engagement on content that they post online. These are indicators that we call views or interactions. Then, as clients are engaged individually, programs can use simple trackers in Excel to track their individual chats or messenger or phone-based support provided to clients. In most of our HIV programs, clients are then funneled through ORA to book and access services. ORA, as well as existing program trackers such as the DH2 tracker, may be used for most other reporting needs for virtual interventions. You'll notice that ORA may be used to capture many important HIV program indicators. You can see the indicators in blue, which represent some of the standard indicators for PEPFAR programs. However, DHIS2 is a much more comprehensive tool in terms of reporting and would include several other indicators and disaggregations not captured in ORA and not shown on the slide. Our programs use DHIS2 for comprehensive program tracking, including for the clients who are reached online and referred to services via ORA. ORA primarily tracks and reports on those 4 custom indicators shown in red, which demonstrate the number of clients who access and use the ORA system, including the number of clients who do a risk assessment on ORA, number who book appointments on ORA, number of clients who attend their appointment, which was booked on ORA, and the number of services provided to clients who book and arrive for their appointment. In some circumstances, special circumstances, ORA could be leveraged for reporting. And we've done this among networks of private providers who are not expected to use the program's existing monitoring tools. And those results, of course, would be integrated into the broader program tracking and reporting systems. We'll go to the next slide. So we worked on this framework with the Global Fund and UNAIDS, which was published last week in Going Online, a Budgeting and Programming Aid for Virtual HIV Interventions. You can download this guide from the link on this slide. And in this document, you can find explanations of each of the approaches, data security and privacy considerations, as well as budgeting guidance. Next slide. We also documented some guidance for the secure use of mobile devices and apps, specifically for programs providing virtual client support. So this can be useful for programs implementing online HIV outreach and virtual case management. You can download the guide from the link on this slide. Next slide. Since 2017, HIV programs in over 35 countries have received technical assistance on going online approaches. In the current fiscal year, 27 countries are investing in ORWS-based applications. You can see those in red or pink on the slide, and several others in yellow have received just technical assistance for planning their approach. We'll go to the next slide. And we have 4 rapid fire presentations on hot or innovative approaches within the field of virtual HIV interventions. Each will have 7 minutes, followed by a short moderated discussion. And I'll introduce each of the panelists before their presentation. We'll go to the next slide. And first, we're joined by George Isaias, who is the co-founder and chief marketing officer for AI Fluence International based in Kenya. George will be presenting on the cutting edge of artificial intelligence-powered influencer marketing. And at the end, Jen Hecht from Building Healthy Online Communities will lead the discussion on influencer marketing with George. George, please take it away.
Thank you, Ben, and well done for getting through that with a sore throat. Good effort. Yeah, so hello, everyone. It's a pleasure to be here, and thank you, Ben, for the invitation to join this webinar. Yeah, I'm George. I'm the CMO and a co-founder of iFluence, which is Africa's first AI-powered influencer marketing platform, and I'm delighted to share our particularly, I think, unique approach to influencer marketing. Next slide, please. Great, thank you. So yeah, before we begin, I'd like to actually define the various influencer categories, and forgive me if I'm sort of teaching anybody to suck eggs. That's not my intention, but this is crucial to our approach. So depending on the network size, the smallest networks would be nano and micro influencers. So think of them as a sort of regular people, and as you go up the tiers to celebrity, obviously that's when influencers try and commercialize their network as much as possible and have a far bigger reach. Next slide, please. Exactly, so that's where we operate, and this is the contemplation ladder. I guess these are the building blocks for any campaign we run, where we start at the top of this inverted pyramid with awareness and kind of educational messages, and then we work down the pyramid to drive action and maintenance and essentially behavior change. Next slide. And each influencer category has its advantages and disadvantages across each of these steps in the ladder. At the very top, celebrities of high visibility, but very, very low engagement and conversion. And as you work your way down to the nanos and the micros with lower visibility, the engagement and conversion rates are far higher. But obviously, the trick at the micro nano level is to do that at scale. And that's really what we have a solution around. Next, please. And again. So very, very simply put, if I was to summarize exactly what we do into a couple of lines, it would be this. It's targeting opinion leaders and leveraging their trust networks. And we really go big on the word trust to drive relatable and authentic conversations. It's really, authenticity and meaningful engagement, which drives behavior change. So I'll take a couple of minutes to share a little bit of theory around how it works, and take you under the hood of the AI so you can see it in action. Next, please. In so doing, actually, one of the biggest pain points that we solve, and it seems to be a considerable pain point, is measuring impact. If you click forward. Thank you. And so, yeah, I'd like to demonstrate how we do that as well, and how we differentiate between impact and engagement. Thank you. Next. Okay, so here's how it works. So if you were to send us a brief, you'll obviously contain some information on your target audience. So we have an audience first approach to building campaigns. Now, a lot of influencer platforms that exist, probably about 99%, are essentially a marketplace type platform. Influencers register, brands register, there's a bit of a matching process, and then a campaign is initiated. Our approach begins with the audience, and we apply layers of research on that audience to understand them better, and then begin a matching process with influencers. So if you click forward, our first layer of analysis is through social media. That's very much where we live, and we have agreements with the major platforms that allow us extra access to their API and to their data. So the first round of research is through the social media channels, and then we introduce the AI elements, if you go forward, which are particularly neural networks and natural language processing. So neural networks allows us to look at all imagery on social media, and natural language processing allows us to analyze all words. And through that, we can understand an audience's attitudes, behaviors, opinions, lifestyles, to really kind of paint a great picture of the audience that we're targeting. And if you go forward, we wrap up these AI modules in our advanced algorithm. And we can now measure through the 200 data points that we've focused on, previously kind of immeasurable, very intangible things such as IQ, such as objectivity, trust, all of which we will dial up and down based on the brief that we are responding to. So once we've conducted the research, and again, I think this is a very unique part of our approach. If you click forward, the platform reverse engineers its approach to identify a long list of nano and micro influencers that hold that target audience in their immediate trust network. And when we have that long list, before we onboard and invite them to join a campaign, we conduct a filtering process. And if you click forward, there's 3 stages to that process. We look to understand their affinity to the campaign and to a particular message that we're disseminating. We'll analyze in depth the connection they have to their followers. We're really looking for positive vibes and meaningful engagement. And we can also conduct a security audit. And at this point, our clients can also ask questions of the influencers before they are onboarded. So it could be a question soliciting a point of view, like, would you go and eat at a restaurant if you knew the chef was HIV positive, for example. So this is where our clients can get involved to make sure that we are onboarding absolutely the right opinion leaders for our campaign. If you go forward. Okay, so there's a human element to the campaign, and click forward again, please. Once we identify the influencers, they'll be invited to click on a link, which will take them to a secure site. They'll sign a non-disclosure agreement. We'll release the campaign brief, what's expected of them, how long for, and what the incentives are going to be. And then if they want to continue, they'll then sign a contract, which could be ours or our clients. And they then get matched with our CSMs, our community success managers, whose job really is to look after their welfare, make sure that they understand exactly what's expected, but to take a campaign message and unpack it into a relatable way that they can then go and disseminate in whatever language, style, tone, or manner they see fit. The premise here is that they know how to communicate to their network better than anyone else. Allow them to do that, empower them to do that. And they can do so in any language. We can actually analyze through the platform over 85% of African languages, for example. So we communicate with our influencers in English and French. They can then go off and disseminate the message in any language they see fit. Thank you. Next,
hey, George,
slide.
we just have one more minute for your presentation, but if we move the discussion to the very end, you can take 2 full minutes. Just want to let you know.
Okay, fine. All right, I'll move along quickly then. This is an example of a campaign we did with 3,000 nano influencers in Kenya. And as you can see, as it scrolls across, they're all saying the same things, but in different ways. And we managed 3,000 nanos over 3 months with, and they each posted 8 times. And we did that with a team of just 3 people. That speaks to the automation of the platform. If you click forward. Thank you. So we have a couple of tools that I think speak fairly strongly to the various approaches that Ben alluded to earlier, which I'd like to quickly go through. If you click forward. Yeah, and one more time, please. So this is an analysis of one influencer on just Instagram. And what we can see here is a breakdown of that influencer's network. So this is a 58-page in-depth report of just that one person. You know, we can understand who the network is, where they live, their income levels, their ages, the media they consume, their job titles, their industries, where they're based, universities they attended. So we can do this kind of analysis at scale, as you can see as it scrolls down. And if you go forward, yeah, just click forward one more time, please. And we also have a social listening tool as well. And we try and track perceptions and conduct social listening and sentiment analysis at every stage of a campaign. If you click forward again, you'll get a sense of what the reporting looks like. Hopefully not too jumpy on your screens. So yeah, this is a tool that we can deploy at any point, and we try and do so as often as possible to see how we're moving the needle. And Ben, please do shout when I go over time, and I can stop anytime.
Yeah, George, we're about over. So if you have any final remarks,
okay,
it'd be great to hear those now.
Yeah, not a problem at all. So just a final remark is we're a 2-year-old company, and we're working in we're based in Kenya, but we're already working across 15 countries in Africa. And so it's an entirely universal platform, and we can be delivering behavior change campaigns or awareness campaigns on the ground anywhere around the world within just a couple of weeks. And we can really help unclutter the ecosystem of agencies and social media and media buying, etc., by simply identifying the right nano-influencers in the right geographies and entrusting them to deliver the messages on our behalf. So there's a lot more that we can talk about, and I believe that this presentation will be shared after the webinar, as will my contact details. So if you would like to have a deeper demo, please don't hesitate to get in touch. Thank you very much.
Thank you, George. So we'll move on ahead. We'll go to slide 45, and we'll be joined by Daniel Lucas, who is a site coordinator with the KP Star project and in Namibia. He'll be speaking about the deployment of QuickRes, which is an online reservation and case management app that they deployed among 50 clinics in Namibia to support virtual case management and cohort tracking. Abraham Simmons is a consultant with FHI 360's Going Online team, and he will help facilitate the discussion, if we have time remaining, with Daniel on this topic. So Daniel, go ahead and take it away. We'll go to the next slide, Sarah. Thank you. Daniel, go ahead and take it away.
Yes, good afternoon, good morning, everyone, wherever you are, whatever time it is. I'm greatly happy and excited to be with you on this webinar. And can we please go to the next slide, please? Yeah, so next slide, please. Next slide. All right, so I will be taking you through the virtual case management, which we are doing through QuickRes app in Namibia. Now, routine HIV service delivery has been significantly affected by COVID-19 pandemic, and QuickRes, an online reservations and case management app, was introduced in Namibia, particularly to help bridge this gap. We did a pilot in September last year in a partnership with Holfies Bay Corridor Group, which is funded by the KPIF. The results of this pilot exercise helped us to use the routine and refine our rollout strategy on board our various partners. There are obviously more than 50 health facilities that have been added on QuickRes across 10 health districts in Namibia. QuickRes allows clients to book HIV services online, and for health facility-based case managers are remotely monitoring clients on ART and PrEP. They obviously provide phone-based support, tracking clients who are lost to follow-up, scheduling and planning client refill appointments. QuickRes was developed by FHI 360 through EPIC project. About 19 countries globally use QuickRes, including Lesotho, Botswana, and Malawi, to mention a few. Next slide, please. As a client using QuickRes, one would simply visit the mobile responsive site at quickres.org and select their country or the region which they want to make their reservations. They would obviously then be able to play around with HIV and sexually transmitted infections assessment, the booking of appointments for HIV, sexually transmitted infections, ART refills, and other services. On the other hand, the back end, the case managers, outreach workers, and some in some contexts, clinicians can use QuickRes, particularly to monitor the appointments, clinical appointments, report on services that the clients have received, decentralized service referrals, and tracking of DDD, track clients on PrEP and ART, to mention a few. Next slide, please. During this, I have included obviously a slide, a short explainer video that we are using to introduce QuickRes client-facing functions in detail. This video has got it's about 3 minutes long. We are not going to then play this video now, but then you can then do it on your own time to then listen to the promotion demo, which we are then explaining the processes of the functions of QuickRes. Next slide, please. So how does QuickRes actually work? After the website at quickres.org and selecting the country, new clients can play with the risk assessment and start a chat or else request for a callback. New and also existing clients can directly go to the services and select the services that they want to book on the system. After indicating the service type in the second picture, we actually see that the region, it allocates immediately where the clinic is and the type of services this clinic is obviously providing to the clients. Therefore, clients who book appointments with their unique links are assigned automatically to a case manager who owns the tokens on the URL. Next slide, please. As part of few frontier virtual case management, case managers typically support clients, particularly to support clients to book new appointments on ART or for PrEP refills. Next, booking routine HIV testing services, appointments for PrEP cohorts, register services uptake, and decentralized service referrals and tracking. The case managers are also able to review upcoming appointments and give reminders in addition to system-generated reminders that the clients will be receiving. They obviously provide phone-based counseling and support and make sure that make use of the case notes which the case managers are having. Next slide. Next slide, please. As much as I would love to really go around the whole process of QuickRes, I will not be able to do so. So I will just want to take you through some of the very important features on QuickRes. The case manager, can we just have, can you keep on clicking at least 4 times? Then I can just continue. Yes. Now, the clinical actions, the clinical burdens are now highlighted on screen, allow case managers to see updates on services provided by the specific clinic team. This can also be accessible by case managers who may obviously report services that the clients receive at the clinic. Now, highlighted also is the tokens. As you can see, the second one that we are able to view the client information, and also the site coordinator can reassign clinical information, the clinical bookings to a next case manager or else to a online case worker. Next slide.
Daniel, just want to jump in and let you know you have about 45 seconds, a minute remaining. Thank you.
Yep. So how does QuickRes work? QuickRes, if we go much faster, where it is highlighted, it obviously gives data as to how how many tablets the client is still having, and then when the client is due for coming back for refills. Next slide. We have lessons that we have learned throughout the rollout of the QuickRes app. At the start of the rollout, case managers needed obviously a dedicated technical support. In Namibia, virtually all clinic and care settings have been able to leverage the platform to meet their needs. Having routine meetings with all users of QuickRes, we could iron out issues with the system and prevent system whitening errors. Throughout the process, QuickRes is constantly upgrading, and the system users are forwarding their findings or else experiences to the technical supporters to really improve on the QuickRes app that we are having. We have learned new ways to protect our clients and engage them online in terms of avoiding suggestive languages in the SMSs that the system is sending out, and confirming client identification before we start to share any information with the clients. Next slide, please.
Daniel, this has been, we're going to have to go to the next presenter. Thank you so much for your presentation. And we'll also have all your discussion and questions be addressed at the end with Purvi. Thank you, Daniel.
Thank you.
So next we have Jen Hecht, who is the co-founder and director of Building Healthy Online Communities in San Francisco, United States. BHOC works by partnering public health and dating apps to further HIV and STI prevention. She also leads program strategy and evaluation at the San Francisco AIDS Foundation. Today, she'll be speaking on their online partner notification and home testing approaches. And I will help facilitate, if there's time remaining, for the discussion with Jen. So Jen, go ahead and take it away.
Great, thank you so much, Ben. Thanks for the introduction and thanks for the invitation to join you today. Next slide, please. I'm just going to provide a quick small bit of background about Building Healthy Online Communities. As Ben mentioned, we are a consortium of public health organizations and health departments that are working in partnership with dating apps to improve sexual health among dating app users. And we have three primary goals. First and foremost, we advocate for changes in the environment or the features of the apps themselves so that we can achieve permanent solutions that promote health and reduce stigma. An example of this would include being able to add sexual health profile information like being on PrEP or preference to use condoms. We also support partners with advertising and messaging on the apps, and we coordinate communication with the dating sites and apps so that we have a more unified set of requests that are coming from the public health sector to the app owners. Next slide, please. So as Ben mentioned, we are based in the US and we generally prioritize working with apps that have the largest number of users in the US, and most of our work is focused in the US. But we often collaborate with international partners, especially when making suggestions to dating apps about new features. Next slide, please. So one key area that we wanted to explore based on some of our formative research, as well as input from public health, app owners, and app users, was partner notification. When we talked to app owners, they did not want to allow users to notify their partners within the app. And so our solution was to develop a standalone site called tellyourpartner.org, which allows individuals who get an STD diagnosis to notify their partners anonymously via text. We worked closely with some of our predecessors, creators of inspot.org, which allowed users to do this similar thing using email. And we added the option of texting to notify partners, since we had data from our research that the most frequently exchanged information between partners who met online was phone numbers. One concern during development was whether misuse had happened, and the similar sites that we worked with during development reported very, very low instances of misuse. Next slide, please. So the way it works is that users of the site can select up to 6 partners and to notify at a time and choose which diseases to notify their partners about. Users simply enter their partner's phone numbers and which disease they were potentially exposed to. The recipient receives a discrete text with information directing them to get a test for STIs. And several of the apps, including Grindr's FAQ articles, now link to tellyourpartner.org. Our partners at National Coalition of STD Directors, also based in the US, now run this site, and it is currently operating as a US-based service only. Next slide, please. So since we launched Tell Your Partner about 2 years ago, we've seen a number of successes. The website is easy to use. It's very quick and simple to anonymously notify a partner of a possible exposure to an STI. We've also had several of our app partners linked to the site. We've had a high volume of users, and many health departments have also begun using the site to support their existing partner notification processes. Next slide, please. As I mentioned, we no longer run this site and have turned over maintenance to our partners at National Coalition of STD Directors, or NCSD. During our first year, we had very low, I can count on one hand, instances of misuse. And around the time we made the transition to NCSD, some videos turned up online that shared the idea it could be a good idea to prank someone by sending fraudulent messages through sites of these kinds of sites. Unfortunately, some of these videos did get a lot of views, and the instances of misuse of the site increased substantially. While I'm no longer directly overseeing the site, I can share some information from our partners as to steps they've taken to address these issues. First, by adding a confirmation code that sends an email to the user to allow for verification of the user. Second, by limiting the number of messages that can be sent per month. Third, by removing the email option, so it is now text only. And fourth, they've created an online portal for people who do receive a prank message to report and block the sender. Next slide, please. In my remaining 2 minutes, I'm just going to share a few details about another project that we launched last year called Take Me Home. Next slide, please. In some of our research about app users, we found that 22% of MSM on dating apps had never tested for HIV. And we also found very strong support, 77%, that app users wanted to be able to order home tests through the apps. Next slide. So here you can see what, so we created a platform for people to order a home HIV test, and our app partners are helping us promote it. Here you can see what the site looks like on a phone, which is how most users get to it. The design is intended to be engaging and simple to reach our target audience who shared in user interviews that they prioritize discreet, free, and non-judgmental services. The experience for the participant is that they see a message, again, typically on a dating site, which links them to our platform. There are then 4 simple questions that the user must complete before entering their name and mailing address to order a kit. Users can order an HIV oral test kit in about 1 minute and a lab-based kit in 3 to 4 minutes. Should an individual have a preliminary positive test, they are directed back to our site where they're encouraged to get confirmatory testing and given local resources to care. Next slide, please. The site was built to host as many state and local health jurisdictions as possible, and adding a new location is really a very straightforward process that can take as little as a few days once contracting and payment is completed. Costs do not increase with new sites being added. Next slide, please. We've now sent out nearly 6,000 kits and have 20 different jurisdictions participating. A third of our users to date reported that they have never tested before, and they're working with local health, and we're currently working with local health departments to complete new case matches through their surveillance departments. Next slide, please. Thank you for your time. Hopefully I answered most of your questions, but I am available if you have additional questions, and please follow us on Twitter at BHOC Partners.
Great, thank you, Jen. We have actually a minute for mini discussion. I have one question. You presented on partner notification and home testing as 2 separate activities, but have you linked these together or considered linking them together so that the messages sent to those potentially exposed partners includes a recommendation or a link so that they could order a home test?
Ben, that's a great idea. Yes, we have been talking to our partners at NCSD. We link to Tell Your Partner on our home test site. And then we've also been in communication with them about linking to us as well. So we do have that open communication going, and definitely makes sense to connect these 2 dots. So very, very good suggestion. Thank you, Ben.
Great. And I have one other question. In some of our global HIV programs, when we do partner notification for people living with HIV, it's usually it's a required component to do a violence screening so that each person that the person living with HIV might refer is screened for the potential or the risk of them experiencing violence because they're making this kind of a referral. And I'm wondering if this has come up in the planning or the discussion, or is something that might be important that you might want to look into in the future to sort of embed that risk screening as a step prior to the system sending out those referrals.
Ben, thanks for suggesting this. That has been mentioned to me actually from, I think, a prior presentation that I did, and it is not something that is currently a part of our tool, and we would certainly love to learn more and explore. So I hope to gather some resources from you all. Thank you so much.
Great. Thank you so much, Jen. We're going to move on to our final hot topic presentation. Becky Sithole is a technical advisor for the EVIC project in Eswatini with FHI 360. He has overseen the implementation of several digital HIV interventions, and particularly in the advent of COVID-19. So today, Becky will be presenting on telehealth consultations for mental health offered by the project in Eswatini, and he'll be joined by Robin Dayton, technical advisor for gender for FHI 360, who will facilitate the discussion. Becky, go ahead and take it away.
Good morning, good afternoon, everyone. So just for background on what we are doing in Eswatini. So psychosocial support, which will be mentioned as PSS for the presentation, is part of our comprehensive services. So it is provided by a professional counselor, and we also have trained outreach workers as first-line supporters. And PSS support was in person prior to COVID, and we have then adapted it to provide the services virtually since COVID. So part of our PSS service include education on mental health issues, providing PSS support based on standard screening tool, and referrals to government and other organizations where cases require additional support. Also, the program was not funded initially for GBV support, but we are adding it as a part of our comprehensive services. Next slide, please. So this slide is on our adaptation during COVID-19. So we moved it virtually, and also social media promotions were done to create demand for the service. And outreach workers were also engaged clients through WhatsApp chats, and clients book PSS services on Aura, sometimes being assisted by outreach staff. And PSS counselor then will call clients during scheduled appointments for PSS sessions. Next slide, please. So for demand creation of these services, outreach workers were trained as frontline supporters to use online and virtual platforms for demand creation for services, and they provide this first line support and refer to the PSS counselor or other institutions through national referral systems. Outreach workers also use a standard screening tool to identify these cases, and peer education using social media and other platforms are provided. We also support clients in the HIV cascade, including peer navigation through this PSS support. Next slide, please. So we also do demand on social media. So social media advertisements link people directly to Aura to book PSS services. And these adverts also link to messenger chat, connecting to staff for additional questions and answers. And staff and counselors help clients access services, including by linking clients to our website, which is the True Eswatini website, to book for different services. And also we have adverts that are tailored for each target population. Next slide, please. So this slide also elaborates on our demand creation using social media. So we use different platforms, including Facebook, Twitter, Instagram, WhatsApp groups, and personal staff and outreach worker status updates to post adverts for demand creation. And we also highlight that Facebook and WhatsApp are the mostly popular used by clients. Next slide, please. So this, next slide, please. I think I've touched already on this one. Next slide, please. So this slide summarizes our achievement. This is from October 2020 actually to March 2021. So in total, we have provided services to 107 clients. And we are also showing the kind of support that has been given to clients in the next graph on the right side. Next slide, please. So this is my last slide. It is on challenges in providing the service. So there is low demand for mental health services because most people are unfamiliar about these services generally in Eswatini. And in-person provision of the PSS services integrated into client flow at mobile clinic helped create demand. Now, the switching to virtual delivery led to reduced uptake. Clients typically prefer in-person counselor services. And also, lastly, there were some service disruptions when we transitioned the service to a KP implementing partner, including new PSS officer. So existing clients developing a trust with new provider, it took some time. So this is the end of my presentation. Thank you.
Great, thank you so much, Becky. We do have some additional time. Robin, if you have some questions of your own or those from the chat, you can go ahead and start the discussion. You should have around 3.5 minutes.
Okay, perfect. So Becky, let me just start with a question that I know you and I have talked a lot about. You mentioned that issue of low interest in these mental health services. And so I wondered if you could comment on the different demand generation strategies that you've been using, which has been the most effective? And then do you think there are any priority groups that are really left out of that strategy that you need to reach in other ways?
Thank you, Robin. So what has been working very well? I mean, as I've mentioned that the demand for this kind of mental health services is not part of the upbringing of most people here. So what has worked well is, creating demand through the in-person practice that we have been doing prior to COVID. I think we have been seeing that, creating a lot of demand. But when we transition to, the virtual platforms, what we are seeing creating more demand is the use of, the interaction through WhatsApp platforms as well as Facebook. I think the interaction for most people, because I think there is the gap for people to be educated about, seeking these services. So whatever then becomes an interaction with the clients, we are seeing creating more demand, whether it has been in the past, the in-person, and now during the COVID, the interaction through the different platforms, we are seeing more of that, creating demand when people are being educated about the importance of seeking these services.
Mm-hmm.
So the other question,
go ahead. Well, Becky, I wonder, could you just comment? There was a question in the chat about the breakdown of who is getting these services, and I wonder if you could just say, in thinking about that priority group question, are these services, mostly do you have sex workers coming, men who have sex with men? Is there a breakdown by key population or by HIV status?
Okay, we can provide the breakdown, but mostly, they're being accessed by female sex workers and we are also seeing younger MSM coming and uptaking these services. And the other one relates to your prior question in terms of who are populations that are being left behind. So we have the hidden populations, and they're still hidden in accessing these services, like all the MSM, they're not coming forward, and some pockets of female sex workers, depending on where they trade. So there are also some that are being, not coming forward to access.
Great. Thank you so much, Becky. I think, Ben, it seems like just time-wise, I should turn back over to you now, right?
Sounds great. Yeah, so I'll hand it over to Purvi Shah for closing remarks and additional discussion. Purvi is a regional consultant with the WHO and UNAIDS, focusing on virtual HIV interventions and innovative HIV testing modalities. Purvi, the floor is yours.
Thank you, Ben. And it's been a real pleasure to be attending this webinar and actually facilitating the discussion today. It's been so many great learnings that I'm taking away today. I just had a couple of questions for the presenters. I'll go with George first. So George, how do we really ensure the quality of content that is posted by the influencers? I think I was looking at the questions in the Q&A section, and I think many of them focused on things like, what are some of the measures that are in place to protect client information, because we're looking at a lot of social listening activities under your model, and how do you ensure that all of that data is secured from the client's perspective? So George. George,
are you there? Can you unmute your microphone?
okay, maybe we can get back to George later.
Yes.
My next question would be to Daniel. When we talk of virtual case management platforms like QuickRes, it's obvious that we are looking at places or populations that can access the internet and the website. Do you have any alternatives for countries and regions where access to internet is not that great? This is just a general question that I keep facing when I talk to countries. So over to you, Daniel.
Yes, thank you so much for the question. We obviously have got ways in place for that. If a person does not, obviously QuickRes requires a smartphone. The client should have a smartphone to operate QuickRes, but in the event that there is no network for internet and the person does not also have a smartphone, it does not disqualify the person to receive the services. The online outreach workers and the case managers can still, through phone calls, engage with the client, and then the appointments can be made, and then the services will still continue to be provided. The person will receive text messages on the phone that they are using. Yeah.
Thank you, Daniel. I think that's a great alternative, and it's important that countries know that virtual interventions are not restricted to only internet-based interventions. They can be over a phone call or a simple SMS, because that often becomes like a barrier for most countries to accept the fact that virtual interventions can be implemented in their setting as well. So thank you, Daniel, for that option. My third question is to Jen. Jen, I just was wondering, when you have clients enter phone numbers of their partners on your website or application, have you ever faced a challenge, in terms of consent issues from the partner's side, like the partner who's getting referred actually turns back and asks you, who gave you my phone number, or how did you get in touch with me, or I never consented, or anything like that? Any such experiences that you would like to share?
Yeah, thanks for asking. I think what we've experienced, not so much around consent, because it is just kind of a communication, but really every once in a while, yes, we have had partners who seemed a bit surprised. And when they've reached out to us, we have kind of a template email that we send them that describes the process a little bit more. And we explain the reason for why we keep it anonymous. We explain the reason for how the process is set up. And once we give that context, I think users, the people who are receiving the messages generally feel sort of a sense of relief, like, okay, I understand this is a credible organization. Now I understand why I'm getting this message. Now I understand what I might do with it. So I think it doesn't happen all that often, but when that does happen, that's kind of our response, and that's usually mitigated the situation.
Okay, thank you so much, Jen. I think that was useful. I think my questions are over. Maybe we can move on to the next slide. I just wanted to note several upcoming related webinars that we have in this month. So the first one is on 7th of June. It will be held as a side event alongside the UN high-level meeting on HIV/AIDS and will focus on self-care interventions. The next one is within the EPIC Project's Decentralized Drug Distribution Learning Collaborative on virtual case management. This will be on the 17th of June. And I will be facilitating one with the WHO and UNAIDS on 29th of June that is related to today's topic as well. So please register yourself for all these great webinars and learn more about virtual interventions. With that, I just would like to conclude with my remarks. Firstly, I would like to congratulate FHI 360 and all the presenters for a wonderful and successful webinar. I was really looking forward to this webinar actually, because it promised newer generation approaches that the program can use and integrate. And I must say that I'm really pleased with what I saw and learned today. Virtual interventions was being actually used sporadically by a lot of HIV programs in the past, but it has been recognized as an important strategy only after COVID came into our lives. So in a way, thanks to COVID, virtual interventions actually allows us to provide user-centered and holistic options for not just reaching to populations with the right information, but also actually ensuring that we link and track them on service uptake. And some of the main takeaways that I would like to highlight from today's presentations for me were, we've always been faced challenges when we talk of influencers. We face this challenge that who's going to be the target audience? Are the followers of these influencers our real target audiences? And with the model that I saw by AI Fluence, I think they're doing a lot of adequate research to understand the audiences and their behaviors. And that would actually allow us to plan our interventions much better. Virtual case management has also become increasingly important to reach existing cohorts virtually during COVID, or even tracking newer populations for uptake of services. And I just wanted to highlight that, you must have read in some of the reports, 62% of the new infections are among key populations and their partners. And we all understand how important it is to bring partners into the program and provide them access to services. And I think, what Jen presented in terms of home delivery of self-test kits can actually be a game changer, especially for success of these strategies like, index testing or social network-based testing. So, Ben's comment on clubbing the two makes a lot of sense. And I think we should definitely be looking at that. And lastly, I think in the race of reaching and testing populations, we often forget about an important component, which is psychosocial support, and which I think should be embedded as part of our service delivery system in a better way. And I think it's time to change our traditional methods to more acceptable ways of communicating with key populations for better outputs. WHO and UNAIDS is committed to providing TA guidance to countries, programs that will not only accelerate our move towards the 95-95-95 goals, but also will help us in mitigating the COVID impact on our programs. We will also soon be coming up with a technical brief on virtual interventions themed as Innovate, Implement, and Integrate, which will actually help countries prioritize these approaches for their programs. And so with this, I would like to end my remarks by thanking everyone on this webinar for taking their time and the great discussions that we've had. Over to Ben.
Thank you all, and thank you, Purvi, for the closing remarks. This concludes the webinar, and you'll be receiving an email with the PowerPoint and webinar recording. And enjoy the rest of your day, evening, or morning. Goodbye, everyone.